Hello, good evening, everyone. I welcome you all to another session of emergency medicine updates. And we have today with us Dr. Sriram. Dr. Sriram is going to talk to us about newer updates in pulmonology, uh, respiratory emergencies. So, Dr. Sriram doesn't need an introduction. He's a very senior faculty. He has been with Glen Eagles for a very long time, and he has done his MD and he has also done his MRCEM. And he is an ACLS instructor, an ATLS instructor, and he's very active in the academic circle. He's quite an active member in conducting our monthly emergency meetings. And I am really happy to introduce him, and I look forward to the talk. Uh, we're going to get a lot of updates from Dr. Sriram. So over to you, Sriram. You can take us through of a few 45 minutes of a good lecture, and then we'll have a question and answer session.
Thank you, Dr. Vasim, for your kind words. Thank you, Semi Board, for giving an opportunity. So, thank you all the students who want to listen here or anything there. Today, I've just told them that we will do an update on all the respiratory disease. As you know, for the past 1 month or anything, there are a lot of updates has come in cardiovascular and stroke. There have been a lot of updates. So we just thought that why can't we do same for the respiratory system? What are the challenges has happened there? What is new has happened in respiratory diseases? I'll share my PowerPoint and I hope you can able to see.
Yeah, your slides are visible.
Okay.
Full screen?
Yeah. So we will discuss about the 2025-26 guidelines. So I'm going to discuss on some of the topics like community acquired pneumonia, pneumothorax, asthma, COPD, ARDS, what's going on kind of things. For this, the guidelines I have taken a lot of things from American Thoracic Society, British Thoracic Society, GINA, and Gold guidelines kind of things. Obviously, there's a chest which involves kind of things. So take an example. So this is common things will be there. 45-year-old came with fever, cough, shortness of breath. You do a vitals. Vitals, you know there is a heart rate is around 125, temperature is 40.2, saturating around 90. So it tells you there is the system is going to be kind of things, respiratory system kind of things. What do you do next? Apart from the clinical examination or anything there, we do the basic ABG, chest X-ray. So X-ray, ECG shows sinus tachycardia, X-ray. What does the X-ray shows? X-ray shows homogeneous opacity, the right lower lobe kind of things would be there. So this is nothing but a community acquired cap, what we call it as a cap, right lower lobe consolidation kind of things. How do you manage community acquired pneumonia? We all been trained to do curb score. So curb is confusion, urea, respiratory rate, blood pressure, age 65. Now, latestly, they are saying that even uremia need not see CRB 65 kind of things will be there. Where 0 to 1 is a low severe, where we can treat the patient outpatient. So, moderate severity if curb score of 2 and severe is 3 to 5. These are all inpatients kind of things. So, curb 65 is basically to determine whether it's an outpatient or inpatient kind of things will be there. And also the severity goes around the death, as you know, that when a low score it's around 3%, when you go higher, it can go reach up to 40%. So the treatment of choice for a oral therapy or anything there, penicillin, amoxicillin is being used when you're admitting intravenously amoxicillin, cloud, and also if you need a Legionella, you had clarithromycin kind of things would be there. So this is the current scenario which has been there. Once you're an inpatient, we do a lot of port score. We do the port score, depends upon the severity kind of things, how bad is the, if they can lead into sepsis or anything there, based on that, do that. So we just want to know, so is there any change in the community acquired pneumonia guidelines? So American Thoracic Society has made 4 points. First is the one, use lot of lung ultrasound. So lung ultrasounds has a more specificity around 93 percentage comparable to what we have chest CT compared to CT. It has a specificity of around 98 percentage kind of things would be there. So especially in a pediatric age group when they want a radiation or anything, their lung ultrasound. Nowadays people are trying to become a very good function. We can do a lung ultrasound. So what are the features you can find in lung ultrasound? Basically a consolidation. Consolidation is what it will be an hepatization of the lung. Means there will be in the lung, there will be like a resemblance of liver tissue kind of things. And also it features dynamic air program. It can also have localized B lines, irregular pleural line, or also pleural effusion you can detect. So this is expertise nowadays it be there. It is a conditional recommendation where you can able to do it, which majority of the centers are able to do it. You can use the lung ultrasounds. Next thing, usage of antibiotic when there is a cap has been detected with positive respiratory virus kind of things. So when you do a swab, nowadays a lot of respiratory panel is there, biomarkers which has been there. So lot of influenza A, B, para-influenza, adeno, human metapneumovirus. All those things can be detected with a single swab with the reporting time of less than 30 minutes will be there. Suppose if they become positive for it, do you still, we have been trained that when you say community acquired pneumonia, it is more of a bacterial infection. So you have to treat with an antibiotic. Whether if there is a respiratory virus positive, whether to treat with antibiotic, yes or no. For that, you have to think it is whether you are treating the patient with outpatients or inpatients. Outpatient without comorbidities, patients have a positive finding. Patient is comfortable. That means, clinically, patient is stable. Clinical stability, what is the criteria? I will put it on later on. If it's stable, they say don't treat with antibiotic. You need not give prescribe empiric antibiotic for those patients. But those patients who has a comorbid illness, some comorbid illness. So I will give you a comorbid illness list. So these are the comorbid list: chronic pulmonary disease, end-stage liver disease, end-stage renal disease, cardiovascular, alcoholism, neoplastic. All those things, almost everyone agreed, more than 50% agreed there to prescribe an antibiotic. Less than 50% of the people where have neurological disease, chronic liver disease, concurrent corticosteroid therapy, diabetes, chronic kidney disease, less than 50% of the same, let's give an antibiotic. So if we have any of these comorbids, please prescribe them antibiotic if they have, even if they are going as an outpatients. Let's give a feature on inpatients. Inpatient severe cap or non-severe cap. Both they say prescribe antibiotic. So any inpatients with clinical and imaging evidence of CAP, please prescribe antibiotic because of concern of co-infection of bacteria in those patients. So not only the virus, there will be a concomitant bacterial infection kind of things. It can happen kind of things. So they can have staph, pneumococci, all those things will be there. Klebsiella, they can have all those features can be co-infection. So please prescribe antibiotic this way. This is the current kind of things. I've told you that. How long can we give antibiotic? So I was telling about the outpatient with who's clinically stable, very clinical stability. They say you can give even 3 days. So minimum 3 days, maximum of 5 days. So don't give more antibiotic in those patients. Don't cause antibiotic resistance in those patients. Give a duration of 3 to 5 days kind of things. Even for inpatient with non-severe cap. So if non-severe cap, you can also prescribe the antibiotic for 3 to 5 days, not more than that. In case if the patient is having severe cap when the curve score is around 3 to 5 or anything there, we prescribe longer antibiotic duration kind of things. This is what I was telling about the clinical stability definition. So temperature has to be less than 38, heart rate is less than 100, respiratory rate is less than 24, saturation more than 90 percentage, blood pressure is more than 90, and the mental status is normal. This is the criteria kind of things would be there. Then systemic steroids for CAP. So previously they were telling about the sepsis, septic shock when you are starting on to uh, kind of a vasopressors, you give stress-induced steroids will be there. Now the same concept has come in case of community-acquired pneumonia. So in case of non-severe CAP, please don't give systemic steroid because there is a strong recommend of not using it kind of things will be there. In case of systemic steroid, in case of severe CAP, use systemic steroid. Okay. Like hydrocortisone, 200 mg per day for 8 days kind of things will be there. Yes. Don't use it if it's due to influenza pneumonia. It can worsen kind of things. So now the suggestion is use systemic steroid for severe CAP. And I was telling about the severe pneumonia criteria. So any one major or three or more minor criteria. So major is septic shock or a respiratory failure. Minor is respiratory rate more than 30, PaO2, FiO2 ratio of less than 250, uremia, multilobar infiltrate, confusion, leukopenia, hypothermia, hypotension requiring aggressive fluid therapy. Any of these three minor criteria is all considered as severe CAP. So that's the update about the community acquired pneumonia. I think I've taken in a slow time kind of things will be there. Let's give another example. 23-year-old male brought in by paramedic for chest pain and dyspnea. So blood pressure is normal, heart rate is slightly 110, blood pressure is 125/74, saturation is 95 percentage on rumor, clinical examination and do an X-ray. What does it suggest? Can you all see that? There is a right-sided pneumothorax. So right side pneumothorax, how are we managed normally? We put a aspiration or a drainage test tube or anything there, underwater seal drainage, and then we be there. So we just want to know, is there any current trend in managing the patient's kind of things? So spontaneous, another one is traumatic. Traumatic is same as an ATLS guided. We need to do a large bore tube kind of things will be there. You all know that there will be in the fifth intercostal space anterior. So triangle of safety, you put it kind of things will be there. Upper border of the lower rib, you put a chest tube. In spontaneous pneumothorax, so you all know spontaneous error can be divided into two things. One is primary spontaneous, other is secondary spontaneous kind of things will be there. So management decision is based on clinical stability and patient priorities. If there is a tension pneumothorax or clinically unstable, you know that there is a needle compression and followed by a chest tube. If the patient is symptomatic, then you have to do intervene. Now they say stable and minimally symptomatic may be considered for conservative or observation meaning in case of primary spontaneous pneumothorax. It's like somebody is a morphin, they develop a primary spontaneous, there is a bulla which has been ruptured, patient is considered stable. You just have to monitor. You can slowly resolve. Keep after 3 days, do an X-ray, see how is there. But always give an explanation if they have a respiratory distress or anything that come, we need to do it. The tube kind of things will be there. Secondary spontaneous pneumothorax will require intervention. So they say treat the patient, not the X-ray. So most patient with a primary spontaneous pneumothorax, irrespective of size, mark the word, irrespective of size, can be managed conservatively, provided the same safety criteria, normal vital signs, patient is walking freely around, all those things will be there. Chest tube is reserved for ongoing air leak or cases of failed conservative management. For those who are symptomatic, needle aspiration kind of things. In expert trial, what they do is they do a one-way wall and connect it to a section for in 25 pressures or anything there, 10 centimeters water for half an hour. So previously we were doing aspiration, the whole stuff. So aspiration pressures will be changing or anything there. This one they try to avoid or anything there by giving a suction and do a continuous aspiration effect kind of things. So to mark it, stable patients can be treated with observation, no immediate drainage. If the patient becomes unstable or anything there, you can start doing a needle aspiration is much more recommended than the chest tube for primary spontaneous pneumothorax because they can have ambulatory management will be there. Recurrence prevention. So recurrence prevention, they can use early intervention by doing an VATS procedure can be considered that for patients to prevent the recurrence. So secondary spontaneous. So more or less, they need to do an active intervention like a chest tube or anything there. If there is a persistent air leak, you can do an autologous blood patch or any surgical procedure you can start kind of things will be there. So whenever you do a procedure kind of things, so let's say primary spontaneous pneumothorax, you are sending the patient home or anything, monitoring. If there is a after complete resolution or anything there, you have to tell them that you cannot fly up high and higher altitude for a more than a week, close to a week kind of things will be there. You should never ever go into the underwater seal kind of things. So due to the barotrauma, they can develop again the pneumothorax. So this is basic intervention instruction you have to give to the patients. So in a chest tube, please try to use the small bore or pig. Nowadays, pigtail is more used in the ER nowadays. So pigtail can be used kind of things. In case of a larger pneumothorax, do a chest tubes kind of things. So surgical management is indicated in case of persistent air leak, recurrent ipsilateral pneumothorax. First, contralateral, opposite side, you should intervene. If there is a high occupational, like deep sea drivers, or the patients having VATS procedure kind of things, often preferred for recurrence prevention. Okay, that's all the updates about the primary. Main thing is primary spontaneous pneumothorax kind of things. So there are some updates which is going to be coming in just as actually suggested, the journalists just as suggested by some mid-June or anything there will be more updates for a pneumothorax. It's going to come kind of this. So case 3, 37-year-old asthmatic came with shortness of breath, RS bilateral V's, saturating around 95, respiratory rate around 25. What we do, our usual X-ray, X-ray, no obvious infection kind of things, RSE. So asthma, they have given a global initiative of asthma derivative. They have given a 2025 update with fresh recommendations. Their use of biological therapy is changed kind of things will be there. So increased use of type 2 inflammatory biomarkers like eosinophil. There is a pheno force exhaled nitric oxide, that level you can monitor. See what happens if there is an irritation in the airway. So that will have pheno will be more. So that will tell you there is an inflammation which is going on, kind of things will be there. So national guidelines in Australia everywhere is shifting from SABA only treatment. So people sometimes they use seasonal or anything that they start using only SABA. Even for mild asthma, they are saying that use long-acting beta agonists, not short-acting beta agonists. For status asthmaticus, it continues to be same continuous short-acting beta agonist. You can repeat it three in an hour, repeat it the ipratropium bromide and then there is a steroids, either IV or oral steroids kind of things. In case of refractory, you can start magnesium sulfate 1 to 2 grams IV. Then the question is whether to use an HFNC and NAV. There is always a question mark case of because of in type 1 respiratory failure, which we discussed kind of things with them. So I was telling about the Australia, which is used kind of things. So they do to have smart or marked approaches kind of things will be there. There will be a single maintenance and reliever therapy. So they use a LABA with the steroids combination. You use as a maintenance therapy. Or in case of mild exacerbation, you give it there. You has a reliever therapy also. So patients will have improved outcomes kind of things. Compared to there also reduces the overall healthcare costs and improve the complaints if you are using the same drug. What are the key aspects is that is called two-in-one approach. Instead of using separate steroids, insulin reliever, use one as combining in inhalation steroids like budesonide or mometasone kind of things. They'll have a reduced exacerbation and it's simplified management kind of things will be there. You say guidelines is 1 to 2 inhalation per day. Uh, if you have exacerbation, you can use additional puff kind of things will be there. So basically, they are used in moderate and severe persistent asthma. So this is the current. So acute exacerbation, not. So now they think biological therapy, what we can do kind of things will be there. So these are the concept has happened. So should a monoclonal anti-interleukin 5 antibody be used in adults and children with severe asthma? If you are using that, what is the specific background that is used to basically to start initiation kind of things will be there. In addition to total IgE, so if there is a treatment with the monoclonal anti-IgE audible, can a measurement be there? Can a long-acting inhaled muscarinic antagonist can be used in severe asthma? Should a macrolide, so we are giving azithromycin, clarithromycin, need to be used in severe asthma? So, or monoclonal anti-interleukin 4 can you use in severe asthma? So these are the things in case of refractory asthma. So to prevent the multiple exacerbation, can we give other medications? So this is where the newer changes has happened kind of things. There is a lot of studies of using biological therapy, which the future is going to happen in case of asthma kind of things will be there. So anti-interleukin 5 actually reduces the exacerbation. That's what they found it kind of things will be there. So all map. So whenever there is a newer kind of things, all map. Mepolizumab, Ventralizumab, they are used kind of things will be there. So they are more effects. They may not able to do minimal change in disease pattern threshold kind of things will be there. So, but in case of refractory severe eosinophilic asthma, please use anti-interleukin 5 kind of things. So eosinophil cutoff, it has to be more than 150. Sometimes it can go to 300. Then you can start initiation in case of anti-interleukin 5 kind of things. The cutoff point is more than 150. In case of omalizumab, they say cutoff is more than 260 to identify in case of with a severe allergic asthma, more likely it can be benefit from anti-IgE treatment kind of things, anti-IgE kind of things will be there. So use exhaled nitric oxide cutoff to identify the patient in case of severe allergy so that it will be beneficial in case of treatment. In case of children, severe asthma, long-acting antimuscarinic like tiotropium can be used kind of things. We can use even in case of children, case of severe asthma kind of things. They say don't use macrolide. Don't use chronic macrolide of azithromycin for long-acting, clarithromycin for long days duration. Don't use kind of things will be there. So anti-interleukin-4 dupilumab, it has been used for eosinophilic asthma and also corticosteroid asthma, COPD patients, all those things, biological therapy, they have been used kind of things. That's where the future comes there. So apart from that, you can understand in maintenance therapy in case of severe asthma, a lot of newer biological therapy has come there, which helps the patients kind of things. That's all about the asthma kind of things will be there. He gave an example of COPD. He came for acute respiratory distress kind of things. Patient is tachycardic, he is conscious oriented, hypoxia is there, saturation is around 84%. Bilateral V's and Krebs, as you know, in case of COPD, we do an ABG. ABG shows type 2 respiratory failure kind of things will be there. So, in case of type 2 respiratory failure, you want the oxygen level to be somewhere around 88 to 92. So you are, in case of severe acidosis, you are going to start an NAV kind of things will be there. What are the key practicing changes in case of COPD? Please, apart from managing what is happening in COPD, you are going to give patients will be having a nebulization, some kind of an NIV will be required kind of thing. NIV versus HFNC, a lot of fight was there. But in case of severe COPD, NIV takes over kind of things will be there compared to HFNC. HFNC, they have started using in moderate asthma, in case of mild kind of things, patient comfortable kind of things will be there. In case of maintenance therapy, even one moderate exacerbation, they thought you have to escalate the treatment kind of things. So previously there was 2 to 3 and all. Now it's actually a one moderate kind of things will be there. If you if you know the previous guidelines or anything, then more likely will tell you that there is A, B, C, D guidelines and all was there based on the symptoms kind of things. Maybe the patient is having shortness of breath kind of things. CAT score, they have a CAT score and risk kind of things will be there. Higher risk, lower risk. That and all is been C and D has been abolished kind of things. It's more of A, B, and E kind of things. Goal is not only the symptom relief, is also the long-term disease control will be there. There will be a phenotypes we have there. When you have a biological therapy where you can reduce it kind of things for tailored therapy, we can do multi-morbidity highlights kind of things. So before treatment, they confirm with a spirometry, CAT score, and then based on the symptoms, how much exacerbation is there, you can check the blood eosinophil. That is a major thing for doing an inhalation corticosteroids will be there. As I told you, C and D has been removed. A, B, and E for the exacerbation. Even if it's a one or more, you are considered as a group E kind of things will be there when you have up to go. So group A, we have a low symptoms, no exacerbation. Group B is high symptoms, no exacerbations kind of things will be there. Group A, you are going to have a LABA or LAMA kind of thing, long-acting kind of things, antimuscarinic, long-acting beta blocker kind of thing. Group B, you can have, because of higher symptoms, you are going to do both LABA plus LAMA. This is better than doing a monotherapy kind of things will be there. When you have exacerbation, use both LABA plus LAMA, and also you can use inhalation corticosteroid, especially if the eosinophil count is more than 300 kind of things will be there. So if the exacerbation is high, but eosinophil count is on the lower also, you can use. Don't use inhalation corticosteroid if the eosinophil count is less than 100 cells per microliter. So in case of persistent symptoms, ensure there is a adherence kind of things. Escalate to triple therapy. So beyond triple therapy, what is there kind of things? So you can use This is where you can use an azithromycin, biological therapy, roflumilast in case of chronic bronchitis kind of things. You can use kind of things. So, so acute exacerbation treatment is oxygen target. There is nothing changed. Bronchodilator, steroids, antibiotic. So antibiotic criteria is in case of COPD is two of the three kind of things. Worsening sort of the purulent sputum. There will be lot of secretions. Will be there lot of sputum production kind of things. Out of these three, there is any two is there. You can start on antibiotics. NIV, if the patient is having a respiratory acidosis, if the patient is clinically unstable, they require ICU kind of things. So that's the kind of things in case of COPD. You know the triple therapy you can do, and then after triple therapy, other medication is Flimast, biological therapy you can use kind of things. ARDS. So you all know that ARDS there is a Berlin criteria. So mild, moderate, severe. So PO to FiO2 ratio less than 300, you will get it mild. 200, 100 to 200 moderate, less than 100 is severe kind of things. So you all know that core principle of lung protective kind of things. Use a low tidal volume and also the maintain the plateau pressure less than 30, not go to 40 or anything there. You maintain the plateau pressure kind of things. You can use a higher PEEP kind of things. Previously, we were trying to give long recruitment maneuvers. We were giving long. So you give a PEEP of 15, all those stuff and all lung recruitment maneuver. Now they say it is causing harm. It is strongly recommend discouragement or not at all recommended. I will tell again, recruitment minimums are not kind of things will be there. Now, currently, in case of ARDS, prone position, we all know after the COVID, prone position, keep it around 12 to 16 hours per day. It improves the outcome, reduces the mortality kind of things will be there. So, recommended is low tidal volume nutrition. In case of need an higher PEEP, you can keep a higher PEEP prone position. Basically, conditionally, if you can give corticosteroids or anything there, you can give a corticosteroid. Still, patient is not improving, then you can give a neuromuscular blockade kind of things will be there. After the prone corticosteroid, nothing helps. ECMO can be used kind of things. High frequency oscillation ventilation is not at all recommended kind of things. So that's the update which has come in. Yeah, yes. Just a small point, I will just, since because we are using HFNC kind of things, more and more frequency is used. So whether it's comparable to NIV kind of things, that discussion is going on for quite some time kind of things. I've added HFNC, what currently they are telling kind of things I've had. So don't worry, this is my last slide kind of things I will try to do kind of things. They say in case of acute hypoxic respiratory failure, where you are using only oxygen therapy, HFNC adds benefit kind of things. So in case of only giving patient is having type 1 respiratory failure, if they have only going to give only oxygen, please consider HFNC kind of things will be there. So the for patient comfortable is important, use HFNC. Patients prefers patients sometimes NAV is troublesome for their patients kind of things. They don't feel comfortable using uh, NAV. Oh, those patients you use HFNC kind of things will be there. So if you are using NAV for type 2 respiratory failure in case of a severe COPD, all those things, in between breaks, you can use HFNC instead of giving a continuous conventional oxygen therapy kind of things will be there. After extubation kind of things, you can use HFNC rather, especially in case of a non-surgical patient. Use HFNC in case of, let's say, bronchoscopy. If you are doing a bronchoscopy or anything there, instead of giving an oxygen, you can use an HFNC kind of things with people. In case of high risk of extubation failure, NIV is generally recommended kind of things will be there. So in case of COPD, acute respiratory failure, there is a lot of discussion is one. In case of severe kind of things, what happens? You have to use NIV. NIV has major advantage than HFNC in those patients kind of things will be there. So HFNC, more or less, you are going to start at 30 to 60 liters kind of things will be there. It can produces minimal PEEP. So as simple as the conventional oxygen, minimal PEEP kind of things will be there. Based on saturation, you can increase the FiO2 in those patient kind of things. Then you titrate based on the symptoms kind of things will be there. That's how you start giving an HFNC kind of things. So, so these are the some of the updates which has been happened kind of things. Rather than talking only theory, I thought of telling you crisply what are the updates are. But over to Wasim to add on the points, or if there is any questions, we are more than happy to do kind of things will be there.
That was a really wonderful talk, Sriram. You put together a lot of information, and it was really useful. So we'll have questions first, and probably then I will summarize, and we can close. To the you can ask questions, or you can even put it in the chat box. So
Wasim bhai, it's you, me, and Yashoda Hospital. So,
okay.
so
So
you can.
they can raise a hand or ask questions. There's another person. Oh, okay. Fine. We still have it open if someone can figure out how to ask the question, because I can see that raise a hand option is there. If you can do that, or if you have any questions. But a really interesting talk. I was actually listening very intently to your talk. I'm the moderator, but again, it was very interesting. So, Curb 65, it's been there. I think we've been listening to Curb 65 almost for about 15 years, and people are still um, they're not talking about adding saturation in it. If you see, you get a young guy who's not confused, whose urea is fine, who's not very tachypnic, but his saturation is around 80% in room air. Definitely, we're going to put him on oxygen and keep him in the hospital. So I think soon we should move towards Curb's 65 score. I think that S should be the saturation level, because whatever said and done, we always look at the saturation level. And the other one which you mentioned was give for community acquired pneumonia. You when they have comorbids, you start them on antibiotics. So there were a lot of comorbids there, but I just to reinforce to everyone, hypertension won't be a comorbid. I'm right, right? It's diabetes, everything else, but hypertension wouldn't be a comorbid unless it's controlled. Yeah, if it's not controlled, probably you can think of it. And for pneumothorax, right now it's more of ambulatory management. We don't, the tubes are becoming smaller and smaller. When you want to pick up that chest tube, think again, do I really want to put in the chest tube? Can I go for a needle? There are these ambulatory devices in UK which they're using. I think Rocket Medical or something. They just put it on the chest, and there's a valve so that the air keeps continuously clearing out of the lungs, and this person can walk around doing their usual work. And regarding asthma, yeah, you said that we are always looking at one nation, one plan, one nation, one medicine. So I think one disease, we want to put everything together. We want to put that LABA and the steroid together, and that should be your reliever as well as your controller. And you also mentioned about COPD, where we are going to now start looking at blood eosinophil count to decide about steroids, and not just give everyone steroids. So we look at the eosinophils, like how you mentioned, and if it's less than 2%, we'll probably even avoid the steroids. So pulmonary embolism, probably I'll just mention that now we are going in for age-adjusted D-dimer, and whenever we have such a patient, don't just think of thrombolysis. Think whether you want to call your interventional radiologist, can we, or your cardiologist. Do you want to do a mechanical thrombectomy? Is the clot as big? So can we do a mechanical thrombectomy? There'll be a lot of patients where it will be very difficult to thrombolyze them. So those patients always think of that. And in the middle of the night, when we have this sort of a patient, getting a CTP protocol, getting a report is so difficult. So start moving towards AI. So there are a
Correct.
lot of people, giving AI, and see there are MRI and CT missions. AI has really come out well. We need to start exploring more and more. And I think I just have one last point to make again, with same thing with regard to ventilator use. Now we are moving towards, I think you spoke a lot about HFNC. Yes, all of us are moving more towards HFNC. The NIV, the face mask which you use is really difficult, and it feels so difficult for the patient. It's so claustrophobic. So patients are preferring HFNC. The trade-off is the high cost of oxygen, but again, for patients' comfort is the main thing. So that HFNC really works well, the success rate well, and recent studies show that the number of patients being put on a ventilator, even invasive mechanical ventilation, the rates are coming down because of high flow nasal cannula compared to NIV. NIV failure rates are high, so HFNC success rates are more. With that, the rates of our ventilator use is really coming down, and I think HFNC is the way to go ahead in the future. So it's really fantastic talk. If there are no questions, I think we'll close the session.
Thank you, Doctor. As I told you, as you also told, HFNC is come way more important there. See, previously we were putting in ICU. Now it has gone into in ER kind of things. Somewhere around there. See, my pulmonologist, one of the pulmonologists used to say, so high flow oxygen touching the cheek, somewhere around it triggers the trigeminal nerve kind of things. It bits calms a bit also. That's what they were telling also. So
Okay,
somewhere around psychologically some benefit. So, yeah,
exactly.
we have all used the NIV. How difficult it is, we all know the kind of things. Especially if they want to somewhere around talk, spit, nothing can be done kind of things. If they feel vomited, all those stuff kind of things. Yeah, HFNC, I know we all need to explore even more kind of things, get into the HFNC mode kind of things will be there. Let's do the kind of thing.
Exactly. So is there someone from Yashoda? I think we'll. Hello, hello. Is there someone from Yashoda? Can we close the session, or do you have any questions?
You'll just have to call them.
Yeah. I think we'll inform them, and probably.
Yes, sir, I'm here, sir.
Yeah. So do we have any questions in the chat box, or
I think so. No questions, sir.
okay?
No problem.
So, yeah,
We have
thank you.
just put it there kind of things in the slides. We have shared it kind of things. If you need to send it or anything there, I can send it there. Okay.
Okay, so
So,
after live, they will get questions in comment box, sir.
Okay.
okay, man.
Shall we end this session, sir?
Yeah.
Yeah. Okay.
Thank you.
Yeah.
Thank you,
Thank you
Simi
so
board,
much.
for
Please
given
go
an
ahead, brother.
opportunity. Thank you, Wasim boy, for being a moderator for my session kind of things will
My
be there.
pleasure. My pleasure. My pleasure. Thank you, everyone, and thanks to the audience who has joined here. Thank you so much, and have a nice evening. Thank you.
Have a nice day. Thank you.